Welcome to the Pediatric Infectious Diarrhea Clinical Symposia Series presented by Johns Hopkins University School of Medicine at ID Care Live. Today is the third segment in a four-part educational series that will explore issues related to the evaluation and management of pediatric diarrhea. Today's session is titled Persistent Pediatric Diarrhea, Is This a Parasitic Infection? With Dr. Ellen Cooper and Dr. Stephen Zinn. My name is Elizabeth Barnett, and I'm Professor of Pediatrics at Boston University School of Medicine. I'm pleased to serve as the chair for this important educational program series. Dr. Cooper is the medical director of the Pediatric and Adolescent HIV program at Boston Medical Center and professor of pediatrics at the Boston University School of Medicine. Dr. Zinn is professor and chairman of the Department of Pediatrics at the University of Maryland School of Medicine and chief of pediatrics at the University of Maryland Medical Center. Welcome, Ellen and Steve.
Thanks.
Today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I will now hand the program over to Dr. Cooper to begin our presentation.
Thanks,
Go ahead,
Elizabeth.
Ellen.
Firstly, I have nothing to disclose. In part one of this presentation, we're going to be looking at an overview of pediatric gastroenteritis and an approach to the differential diagnosis of diarrhea in children. In specifics, we're going to be talking about pediatric parasitic infection of Cryptosporidium and talk about the epidemiology, clinical characteristics, and testing. We will defer our discussion of treatment to part two of this presentation. So first, to give you an overall worldwide perspective of acute gastroenteritis, as most of you know, gastroenteritis is characterized by the sudden onset of diarrhea with or without vomiting. It's generally mild and self-limiting, but it can be severe. And when it is severe, infectious gastroenteritis is most often accountable. It accounts for 10% of all pediatric admissions to hospital, and it's associated with significant morbidity and mortality. Acute diarrhea is a leading cause of child mortality, second only to pneumonia worldwide, and acute gastroenteritis is responsible for 20% of the over 10 million childhood deaths each year. Just to look at an approach to diarrhea, it's often helpful to try to characterize the categories of diarrhea in a pathophysiological manner. So to remind you, osmotic diarrhea, where there's a concentration gradient that increases the water content in stool. And this really accounts for the non-absorbable substrates. And the output of this sort of diarrhea is in general associated with the inability to absorb a certain substrate. Once that substrate is removed, the diarrhea really very promptly abates. With secretory diarrhea, there's an active secretion of water into the gut lumen, and this is characteristic of several of the bacterial and parasitic infections. And here you have epithelial cells in the gut with an abnormal ion transport that are turned into a state of activation, and therefore there's an active secretion of water. The inflammatory categories of diarrhea include intestinal blood, mucus, and a protein exudate. And they're characterized by enteric pathogens that adhere to or invade the gut wall and produce either cytokine release or enterotoxins. Diarrhea can quickly lead to life-threatening complications with dehydration, sepsis, and electrolyte abnormalities, as you well know. So for some of the diagnostic aspects, the clinical assessment is generally sufficient to determine hydration status. But it is important when you're honing your differential diagnosis to try to get the characteristics of the diarrhea by localizing the likely pathogen in either the small bowel or the colon. The characteristics of the feces may help you, as I just mentioned, with blood or mucus, the clinical history of the disease, including whether or not it's a rapid onset or it's been a chronic problem, and then environmental risk factors. Recent contact or exposure to known sources of enteric infection or recent travel is an important part of the history when you see a patient with diarrhea.
I have a question from a listener about whether parasites can be ingested from animal sources and which sources might be important in transmission of parasites from animals to humans.
So many parasites can be transmitted from animal to human, and as we'll see, Cryptosporidium is one of those. And there's a very specific type of Cryptosporidium associated with cattle, and we're going to get to a longer discussion of that. But yes, as long as these are usually fecal-oral associations, and if there is a contamination of either water or food with fecal contamination from animals, there can be a parasitic infection. And these are more or less likely depending on the specific parasite. The general rule is that organisms in the small intestine are associated with a larger, more profuse amount of diarrhea, more electrolyte imbalance, and dehydration. Those pathogens associated with large bowel are more associated with abdominal pain, blood, mucus, and a lower volume of diarrhea. Severe watery diarrhea in the absence of mucus, pus, or blood suggests a secretory diarrhea or malabsorption. And the presence of mucus and blood, as I said before, indicates more invasive pathogens and inflammatory diarrhea, such as we see with several of the bacterial infections. Systemic infection with sepsis may complicate a GI infection. And interestingly, and I think importantly, the presence of vomiting and fever along with diarrhea is really not specific, and especially in children, doesn't really help us in diagnosing a specific pathogen. Here we have a graph or a table to show you some of the characteristics of small intestine versus colon, and you can see that the microorganisms that are associated with those diarrheas are somewhat different. In the small intestine, we see viruses, some enterotoxigenic bacteria, and parasites, specifically Giardia and Cryptosporidium. And it's important to note that these diarrheas are often associated with a secretory type diarrhea. I'm not going to spend a lot of time on this, but I wanted to make sure that you had this for reference.
It looks like the white count, fecal leukocytes, is a test that people are accustomed to ordering, but it doesn't look like it's terribly helpful in diagnosing a parasitic infection. Would you agree with that, Ellen?
I would agree that it's not helpful in diagnosing a parasitic infection. It may be helpful in diagnosing a bacterial infection, and oftentimes I think it's a question of sampling. So oftentimes the stool that's sent to the lab may be the blood, it may be the actual stool, and sometimes whatever the sample is doesn't include the mucus that has the leukocytes in it. So to some extent it's going to be associated with what your sample is. But in general, parasites probably have a lower number of fecal leukocytes, even with a good sample, than, say, bacterial contaminants, which are associated with colonic disease. Whoops. Okay, sorry. The causal agents of infectious diarrhea in children, as you can see, are many. And this is not an inclusive list at all, but it's, again, to help you organize your thoughts as you approach a child with profuse diarrhea, and whether or not it's in the small bowel or the colon, or whether or not you think it's secretory versus inflammatory diarrhea. I want to remind you, in addition, that there are many non-infectious causes of diarrhea that can also be extremely severe.